Right. So today we are now going to get into the management of metastatic non-small cell lung cancer, and we'll start off with the management of oncogene addicted non-small cell lung cancer. Non-small cell lung cancer that has driver mutations, right? So right now, coming to the introduction, around 70% of adenocarcinomas currently have a targetable driver mutation. Okay, and around 5 to 10% of squamous cell carcinomas have a targetable driver mutation. So, in this era of management, currently in metastatic non-small cell lung cancer, you always need to establish for the presence of a targetable driver mutation first, because if such a mutation exists, then treatment will be, targeting that particular driver mutation. So, yeah, for a metastatic non-small cell lung cancer, first of all, obviously you'll do a chest X-ray if the patient has respiratory symptoms, and then you will do a PET CT. This followed by a CT thorax or a imaging of the site which has symptoms. For example, if they have respiratory symptoms, you'll do CT thorax. They have some other symptoms, you'll start off with that particular site. Then for metastatic evaluation, you always do a PET CT, and then you do a biopsy, right? And then you do a molecular study. So all of this needs to happen: metastatic evaluation, a biopsy, and a molecular study. Now, what is the ideal biopsy site in a metastatic non-small cell lung cancer? So the ideal biopsy site is the most accessible site. In a treatment naive patient, there is not much discordance between the primary site and the metastatic site. Unlike a treated patient, a treatment naive patient, you will get equal sensitivity for detection of the driver mutation from the primary site or from the metastatic site. So you always go for the most accessible site. Okay. Now, the next thing that you need to talk about is the testing technique, right? So currently we use NGS, next generation sequencing, and we use DNA based NGS combined with RNA based NGS. Okay, this RNA based NGS is to detect fusions such as the ALK fusion, the ROS fusion, etc. Whereas DNA based NGS can detect the other mutations. Okay, so we use combined DNA and RNA NGS. Now, NGS is of two types. You have amplicon based method and hybrid capture method. This amplicon based method is looks for a fixed number of genes. For example, you have the hotspot 12 panel, right, which looks at only 12 particular genes pertaining to metastatic non-small cell lung cancer. So it is a more focused NGS technique which looks for a preset or a fixed number of genes. Whereas hybrid capture technique is, it detects a larger array of genes. So around 304 genes, right? In Foundation CDX, for example, look, it finds out, detects 304 genes, for example. So wider array of genes are detected by hybrid capture method. So which technique is more practically used? Currently, in most of our setups, we use the amplicon-based technique or the hotspot technique because it can help us detect the meaningful genes. That is your 12 genes, driver mutations that are commonly seen. You can detect with amplicon-based method. Also, amplicon-based method has a shorter turnover time. Okay, so you can quickly detect the driver mutation. Next is the type of sample. So you've got a formalin fixed paraffin embedded sample. You have to use 10% neutral buffered formalin, and you have to embed it in paraffin as well. So this sample needs, it has to be adequately prepared to detect the driver mutations. So that is also very important. The way you prepare the sample, that you have to use 10% buffered formalin, and it needs to be paraffin embedded. Okay. The next question that one may have is, what is the role of liquid biopsy upfront? So liquid biopsy is not used very commonly upfront. You usually go for a solid biopsy because there is not much tumor heterogeneity for driver mutations, like I mentioned earlier. Liquid biopsy can be used where the solid biopsy might not be possible, possibly due to a poor performance status of the patient, right? So patients who are sick or who have a poor performance status or are not in a condition to take a solid biopsy, there you can go for a liquid biopsy. Another scenario where you can use liquid biopsy is Suppose you've done a solid biopsy, but the material is inadequate for molecular testing. In that case, you can go for a liquid biopsy if a repeat biopsy is not feasible. Okay, so I hope you understood that. One more thing you need to note here is that you cannot go for a liquid biopsy upfront, and if the mutation is negative, you cannot conclusively say that the mutation is negative without doing a tissue biopsy. So always go for a tissue biopsy. In cases where tissue biopsy is not feasible or where the tissue biopsy is inadequate for molecular testing, then only you go for liquid biopsy in upfront treatment naive patients. So let's come to EGFR mutations. So EGFR mutations, their incidence is very interesting. So in Caucasian populations, in the Western population, it's seen in 10 to 15% of the population. In Orientals or East Asia, it's seen in 50%. And in our population, it's seen at around 40% of the population. So 40% of all adenocarcinomas. So we're talking about adenocarcinomas here. So that forms a significant chunk, right? So 40% of all adenocarcinomas amongst the Indian population will have an EGFR driver mutation. So that's how prevalent it is. Now, coming to the EGFR pathway, the EGFR is a growth pathway, an epidermal growth factor receptor pathway, and activation of the EGFR receptor activates the RAS-RAF or MAP kinase pathway and the PIK3CA-AKT pathway. So what are the common EGFR mutations that are seen? So the EGFR receptor, it has an extracellular domain, it has a transmembrane domain, and it has an intracellular domain. This intracellular domain consists, within this intracellular domain, right, you have 4 exons where driver mutations leading to lung cancer can occur. So you have exon 18, 19, 20, and 21. So what are the common driver mutations? So the most common one is exon 19 deletion, seen in 45% of patients. Then the second most common is exon 21 L858R, which is seen in 40% of the patients, right? And the third most common is exon 20 insertion, seen in 8 to 10% of patients. So this exon 20 insertion is interesting because these patients are resistant to TKIs, right? EGFR, anti-EGFR TKIs. And you have some rare mutations that are also seen, right? So such as exon 18 G719X, then exon 20 768I, and exon 21 L861Q. So these are some of the rare mutations that are seen. So most commonly you have exon 19 deletion and exon 21 L858R substitution mutation. And these are the mutations with which most of the anti-EGFR TKI trials have been conducted. So let us come to treating the most common set of EGFR mutations, that is exon 19 deletion and L858R mutations. So we'll be talking about the first and second generation TKIs, then the third generation TKIs, then combination therapy. So combination of erlotinib with VEGF inhibitors, the combination of geftinib with chemotherapy, and then of course the third generation TKI combination therapies, which is currently the standard of care. So initially you had the first generation TKIs, which is geftinib and erlotinib, right? And these are the trials, initial trials for geftinib, which compared it with chemotherapy, and erlotinib, which compared it with chemotherapy. So the mechanism of action for first generation TKIs is that it inhibits the wild plus the mutated EGFR. Okay, so both EGFR receptors are inhibited, and geftinib is given at a dose of 250 milligram OD, and erlotinib is given a dose at 150 milligram OD, and erlotinib is given empty stomach. Okay. Now, one point you have to note here is that because it inhibits the wild EGFR receptor as well, it can lead to certain characteristic toxicities. So those include diarrhea, rash, right? Skin toxicities. So you have pruritus, you have erythema, you have acneiform rash, you have diarrhea, you have mucositis, and you also have ILD and LFT derangement. Okay, so these are the characteristic toxicities seen. And you also have CYP3A4 inducers and inhibitor interactions. Now, coming to the second generation TKIs, they are afatinib and dacomatinib. Okay, now afatinib was initially compared with chemotherapy, that is platinum-based doublet, and it showed a PFS benefit in the Lux Lung 3 and 6 trials. And in the Lux Lung 7 trial, it was compared with geftinib and showed a PFS benefit. And dacomatinib was in the Archer 1050 trial. It was compared with first generation anti-EGFR TKS, and it showed a PFS as well as OS benefit. So dacomatinib showed a PFS and OS benefit. Afatinib only showed a PFS benefit. So mechanism of action is, once again, it inhibits both wild plus mutated. Okay, it inhibits both wild and mutated receptor. Now, the interesting thing about the second generation TKS, what is different about it than the first generation TKS, is that it strongly inhibits the wild and mutated receptor. Okay, so it binds and inhibits with a stronger affinity to the wild and mutated TKS. So it has increased efficacy, but also increased toxicity. Okay, so the doses are as follows. Afatinib is 40 mg OD. This is also given on an empty stomach. And dacomatinib is 45 mg OD. That can be given with or without food, doesn't matter. Right? Now, coming to the toxicities are relatively the same. So diarrhea, rash, mucositis, hepatitis, ILD. Okay, so the same toxicity profile as first generation TKS, but the incidence of all these toxicities is much higher due to stronger inhibition of the wild receptor along with the mutated receptor. Okay, so that is the second generation group of TKIs. Now, coming to the third generation TKIs, the third generation here is slightly different, right, in its mechanism of action. So you have osimertinib and recently introduced lacetinib. So you have the wild and mutated EGFR receptor. It binds more specifically to the mutated EGFR receptor when compared to the wild, right? So because it binds more specifically to the mutated EGFR receptor, unlike the first and second generation TKIs, certain toxicities are lesser. Okay. So basically the dose here is osimertinib is 80 mg OD and lasatinib is 240 mg OD. And basically the toxicity profile is different. So you have a decreased incidence of skin and GI toxicities. Okay, although they are seen, but the intensity and the prevalence is much less compared to first and second generation TKs because it binds more specifically to the mutated EGFR receptor. Okay, and apart from that, you also get your ILD and your hepatic toxicity. But what are the other toxicities seen? So unlike the first and second generation TKs, you also have QTC prolongation. So always do an ECG before, and it can also cause cardiomyopathy. So always do an echo before you start treatment with osimertinib, right? And it can also cause keratitis. So these are the unique toxicities of osimertinib, but the skin and GI toxicities are lesser due to selective binding to the mutated EGFR receptor. So osimertinib was initially approved in the second line setting post first generation TKI. Okay, now when you give a first, I have to say something here. When you give a first or second generation TKI, the patient will progress, right, at some point. And around 60% of the patients who progress on first or second generation TKI, they will have something called the T790M mutation, 60% of the patients. And in these patients, third generation drugs such as osimertinib can still work and still be effective. So that is a backdrop for the AURA trial. So if you look at the AURA trial, basically it looked at, right, so basically it looked at osimertinib versus platinum based doublet chemotherapy post progression on first or second generation TKIs with T790M mutation, right? It compared osimertinib plus chemotherapy, and what it found was that post progression on first or second generation TKIs in patients with a T790M mutation post progression, osimertinib had a PFS benefit over platinum-based pemetrexed. So that's how osimertinib was first introduced in the second line setting, post progression of first and second generation TKIs in patients who had T790M mutation. Later on, it came to the first line setting in the FLORA trial, where they compared osimertinib 80 mg versus first generation TKI, that is either geftinib or erlotinib. So this was done in patients with the common EGFR mutation, that is exon 19 deletion and L858R. And what did they find? They found a PFS benefit and ultimately an OS benefit. So that's why osimertinib became the first line regimen of choice. Now, although osimertinib was approved as the first line agent, there were certain lacunae that osimertinib had. For example, if you look at the subgroup analysis, the L858R had decreased survival outcomes compared to exon 19 deletion. So this L858R, which makes up around 40% of EGFR mutations, had lesser outcomes when compared to exon 19 deletion with osimertinib. So we move towards combination therapies to see if we can circumvent some of these deficiencies. Right? Okay. So before we get into combination therapies, let us look at the high-risk features in EGFR mutated lung cancer. So these are some of the high-risk features that patients can have, which makes those patients, less susceptible or less, with, less effective outcomes with EGFR TKIs alone, right? So patients have this, the outcomes are not as good with single agent EGFR, anti-EGFR TKI. So what are those features? Brain mets. Those patients fare poorly with single agent EGFR TKI. TP53 co-mutation. Like we mentioned just earlier with osimertinib, EGFR L858R mutation. Presence of liver metastasis. So to circumvent all these deficiencies, we came up with combination therapies. So the initial combination therapies were with first generation TKIs, and then we moved on to third generation TKI combination therapies. So first generation combination therapies, let's look at them. First is erlotinib plus VEGF inhibitor, right? So basically, this VEGF inhibitor, by taking care of the aberrant blood vessels, will enhance TKI delivery to the tumor. So we had two trials, the NEJ026 trial and the RELAY trial. NEJ026 looked at erlotinib plus bevacizumab, and RELAY trial looked at erlotinib plus ramucirumab. And as you can see here, in both these trials, the L858R mutated patients benefited as well. Unlike with osimertinib alone, erlotinib plus VEGF or VEGFR inhibitor benefited both groups, that is L858R and exon 19 deletion as well. So that is the first combination therapy, EGFR plus VEGF inhibitor. Erlotinib plus VEGF inhibitor. Then the second group of combination therapy is geftinib plus chemotherapy. The rationale being that geftinib leads to a decrease in the expression of thymidate synthetase, right? And that can increase the efficacy of chemotherapy when given together with geftinib. So geftinib leads to decreased expression of thymidate synthetase, which can increase the efficacy of chemotherapy. Okay, so there were two trials in this regard. So there's the Tata trial, which looked at geftinib plus chemo, that is platinum doublet with pemetrexed, followed by geftinib plus PEM maintenance. And they compared that with geftinib alone. And both trials had at similar arms. The Tata trial showed a PFS and OS benefit to combining chemotherapy geftinib, and the NEG009 trial showed a PFS benefit. So this became another option, combination therapy with geftinib with chemotherapy, right? So the initial combination therapies, like I said, were with first generation TKIs. Then we moved on to combination therapies with third generation TKIs, which is the current standard of care. As of this year, with the OS data with these combination therapies, it is the current standard of care. That is third generation TKI with other agents. So in this regard, we have the FLORA-2 trial, which looked at osimertinib plus platinum plus pemetrexed, followed by maintenance with osimertinib and pemetrexed. That was compared with osimertinib alone. That is the FLORA-2 trial, right? In patients with common EGFR mutations. So what did this trial show? There was a significant PFS benefit that was seen at 2 years in the first interim analysis. And you will see here that the benefit was seen regardless of the EGFR mutation type. And also this greatly benefited patients with baseline CNS mets when compared to osimertinib alone. You can see the hazard ratio is 0.47 for patients with brain mets, right? So even the poor subgroups fared really well with this combination therapy. It had a significant PFS benefit. And recently, in the latest update, This translated to a significant OS benefit of around 8% absolute OS benefit at 4 years, as you can see here. And currently, it should be taken as a standard of care, right? As a first line standard of care. And we spoke about this, the various subgroups benefiting. Now, coming to safety of this drug, excuse me. So safety of this drug, if you look at it, mainly you have an increase in grade 3 toxicities, obviously. But a bulk of this toxicity is coming in the form of myelosuppression. If you look over here, right? So anemia, right? Neutropenias, right? And a majority of these increase in toxicities is usually grade 1 and grade 2. The only significant increase in grade 3 toxicity is in the form of neutropenia and anemia, right? So myelosuppression. So that can be taken care of with growth factors and supportive care. So it is a generally well-tolerated treatment regimen. Now, coming to the adverse effects, you can see here that most of the patients received 4 cycles of cisplatin plus pemetrexed plus osimertinib. So once they completed 4 cycles, they went for pemetrexed plus osimertinib maintenance. And you can see here that pemetrexed was discontinued in majority of patients after 8 months. Okay, and then they only continued with osimertinib maintenance. So due to toxicity, pemetrexed maintenance was discontinued in most of the patients after a median time of 8 months. So you can see here that despite discontinuing pemetrexed maintenance, patients showed a PFS and OS benefit. So that shows that even if you discontinue pemetrexed maintenance, that initial period with chemotherapy leads to that increase in PFS and OS, right? So that is very important. So that is something that they saw in this trial. And because of that, you can see here that the adverse effects are front loaded. Okay, so a majority of the adverse effects, including anemia, thrombocytopenia, neutropenia, are usually seen in the first few months, right? So from 0 to 3 months, you can see here it's in blue. 0 to 3 months is where you saw increased anemia, thrombocytopenia, neutropenia. And the moment we came to the 3rd to 9th and greater than 9 months, those toxicities came down significantly. You can see here from the 3rd to 9th month and beyond 9 months, the toxicities came down significantly. So it's front-loaded toxicity when you're giving chemotherapy. The moment you stop chemotherapy, go to pemetrexed maintenance and osimertinib, the toxicity comes down. And most patients don't tolerate pemetrexed maintenance beyond a median time of 8 months. And beyond that, with osimertinib alone, the toxicities come down even further. So the toxicity, although it is there, it is increased, and it's usually in the form of myelosuppression. It is front-loaded. That is something that you need to keep in mind. The next combination therapy was based on the Mariposa trial. It was amivantamab plus lacertinib. Okay, now amivantamab is a bispecific monoclonal antibody. It binds to the extracellular EGFR receptor. So this is located on the extracellular. Unlike the anti-EGFR TKIs, this binds to the extracellular domain of EGFR receptor and also the MET receptor. So the MET receptor is the most common resistance pathway, off-target resistance pathway for EGFR mutated lung cancers. So that is why the MET was also included as part of this drug design. So bispecific antibody that targets EGFR and MET. So the Mariposa trial looked at amivantamab plus lacertinib versus osimertinib. Okay. So lacertinib is another third generation anti-EGFR TKI, right? So they combined a bispecific antibody with a third generation TKI versus osimertinib alone. And what did they show? It showed an increased PFS benefit of 23.7 months versus 16.6 months on initial interim analysis. And later on the latest analysis, what they found was that this translated to a significant OS benefit. You can see an absolute OS benefit of around 12%, which was significant. And once again, all patient groups benefited from this regimen, right? All the significant high-risk groups also benefited from this combination regimen. And once again, you can see over here that this amivantamab plus lacertinib. Before that, I'd like to talk a little bit about how this regimen is given. I forgot to mention that. So in this protocol, amivantamab is given IV, right? So it is given initially on day 1 at a dose. Right. So initially it is given on day 1 at a dose of, it is given initially day 1 at a dose of 350 milligram, and then on day 2, the remaining dose of 700 milligram is given, right? Because 65% of the patients on day 1, they can have hypersensitivity reactions. So to prevent that, we have distributed the doses over day 1 and day 2. Then you give it weekly for 4 more weeks at a dose of 1050 milligram. Okay. And then you switch over to 2 weekly amivantamab at 1050 milligram. So this is given IV. Currently, based on FDA approval, we can also give subcutaneous amivantamab. That is also acceptable, right? So IV causes increased hypersensitivity reactions. So to decrease that, we can also give subcutaneous. That has also been approved. So I hope you understood the dosage. It is given week 1, day 1, 350 milligram, day 2, 700 milligram. Then from day 8 onwards, that is week 2 onwards, it is given 1050 milligram. And that is given for 4 weeks weekly. And then you switch over to 2 weekly 1050 milligram, along with lasatinib, which is given at a dose of 240 milligram OD. Right. So coming to the toxicity, you can see over here that you have rash, paronychia with the nails, dermatitis, stomatitis, venous thromboembolism, you have peripheral edema, pruritus, fatigue, and dry skin. Now you notice here, once again, all this toxicity is front loaded. You usually see it within the first 4 months. With further treatment with the drug, the toxicity rates come down significantly. You can see that over here. And to further decrease the toxicity, you have what is called the skipper protocol and the cocoon protocol. So you can give oral dexamethasone 8 mg BD uh, for 2 days and 1 day prior. So basically how you give it is, yeah, so you can start giving the drug on day -1 and day 0, right? 8 mg BD. And then on the day of the infusion, 8 hours before, you can give Dexa 8 mg again. So 8 mg BD on day -1, day 0, and then you give 8 mg 1 hour before the infusion, and that can significantly decrease the infusion reactions. Of course, currently we are a subcutaneous version is also approved, which has significantly decreased hypersensitivity reaction compared to the IV formulation. But if you're giving the IV formulation, this dexamethasone 2 days prior to and on the day of amivantamab 1 hour before can significantly reduce hypersensitivity reactions based on the skipper protocol. Then, based on the Paloma 3 trial, you can also give oral anticoagulants, which can decrease the venous thromboembolism rate, right? Prophylactic oral anticoagulants. Then, to decrease the dermatological toxicity, such as rash, paronychia, etc., you can give weeks 1 to 12, we can give prophylactic doxycycline upfront, 100 mg BD. And from week 13 plus onwards, you can apply topical clindamycin lotion on the scalp, right? And of course, chlorhexidine for the fingernails and toenails from week 1 onwards. And from week 1 onwards, you can apply a ceramide-based moisturizer. So this is all based on the Cocoon trial to decrease the skin toxicity and the nail toxicity. So week 1 to 12, doxycycline 100 mg BD. Week 13 onwards, clindamycin lotion for the scalp. And from week 1 onwards, chlorhexidine solution for the fingernails and toenails. And from week 1 onwards, ceramide-based moisturizer daily for at least 12 months. So these are protocols you can use, the Skipper, Cocoon, and the Paloma 3 protocol to decrease the toxicity seen with amivantamab plus lasatinib combination. And that is what we saw in the trial. So basically, with this Cocoon protocol, dermatological toxicities came down significantly. With the Skipper protocol, hypersensitivity reactions came down significantly, and with prophylactic anticoagulation, venous thromboembolism came down significantly. So coming in to summarize these third generation combination therapies, Mariposa with amivantamab and lasatinib and Flora 2 with chemotherapy plus osimertinib showed improved outcomes in the poor sub-risk groups that we talked about earlier. So EGFR LA5 it showed improved outcomes. Brain mets showed improved outcomes. Liver mets, TP53 co-mutation, baseline ctDNA positive, etc. All these poor prognostic subgroups, it showed improvement in survival. So based on this, the current standard of care currently is osimertinib. If they ask you an exam regarding EGFR mutated lung cancer, you have to mention the Flora 2 trial first, osimertinib plus platinum plus pemetrexed chemotherapy, right? For 4 to 6 cycles, followed by osimertinib plus pemetrexed maintenance. And this, or you can give amivantamab plus lasitinib. So these are the two standards of care based on the FLORA-2 and MARIPOSA-1 trial. So what is the possible role for osimertinib alone in the current era? So osimertinib alone can still be given for patients who are unable to tolerate combination therapy due to poor PS, comorbidities, etc. So those patients you can consider osimertinib alone. For patients who have exon 19 deletion mutation, which has a better prognosis compared to L858R and don't have other adverse risk features, for those patients you can still consider osimertinib alone. And for patients who prefer less toxic treatment. So if the patient has a particular preference for less toxic treatment, you can also consider giving osimertinib alone. Although it is no longer the current standard of care, osimertinib-based third generation anti-EGFR TKI-based doublets are the current standard of care, but you can still give osimertinib alone in these particular patients, right? What is the relevance of these old treatments, such as first or second generation TKIs alone, or gefitinib in combination with chemotherapy, or erlotinib in combination with anti-angiogenic agents? What is the current role? So obviously, in patients who cannot afford third generation TKIs, who have logistical issues, there you still can give these first or second generation TKIs alone or in combination, right? And you can give these alone, obviously, in poor PS patients who don't, who can't tolerate combination. And obviously, you give combination in patients who have co-mutations like TP53 or high symptomatic burden, right? Or if they have, suppose, L858R mutation and all this, you can give. So with high risk features, you can give combination. And with poor PS and low performance status, you can give single agent EGFR TKIs, first generation, second generation. And this is currently given only in patients who cannot afford the third generation TKIs. Otherwise, the role is, they're currently out of fashion. But in our country, in our setup, especially in the government setup, patients might not be able to afford third generation TKIs. There you can give the combination or EGFR TKI alone. Combination if you have poor prognostic factors such as co-mutations, L858R mutation, or if the patient has brain or liver mets, right? So I hope you understood that. Now, treating exon 20 insertion mutations, this is based on the PAPLON trial. So the PAPLON trial, earlier exon 20 insertion mutations, right? They were found to see, they found out that EGFR TKIs were not effective in exon 20 insertion mutations. But so the previous standard of care was chemotherapy alone. That is platinum-based doublet alone. This PAPLON trial looked at platinum doublet plus amivantamab versus platinum doublet alone. So it challenged the previous first line standard of care. And what they found is this platinum doublet and amivantamab had a PFS benefit. So currently for exon 20 insertion mutations, the standard of care is platinum doublet plus amivantamab based on the PAPLON trial. What about treating rare mutations? So these are the rare mutations that we spoke about earlier that we come across every now and then. These can be treated with, so some of the agents used are osimertinib plus chemo based on the Unicorn trial. This is a phase 2 trial. You can also give afatinib. Afatinib was compared with chemotherapy for these rare mutations and it led to an OS benefit in the Achilles trial. That was a phase 3 trial. So these are some of the options you can use: osimertinib plus chemotherapy or afatinib. Now, let us look at some tangent scenarios. Suppose the patient presents with upfront diffuse brain metastasis. What is the role of WBRT in this scenario? What are the practical issues faced while making a decision regarding WBRT? So, basically, upfront treatment, should we give WBRT or not? So, if you look at most of the trials with third generation TKIs, very few patients have received WBRT or SRS. You can see here with FLORA-2, the osimertinib alone arm received only 8% received WBRT, only 8% received SRS. In FLORA-2, the osimertinib plus chemotherapy arm, it was 7% and 7%. So what is the reason for this? It is because of the increased CNS efficacy of third generation TKIs alone or in combination. You can see here the overall response rate is 87, 88%, right? With combination, the CR rate is 48%. So it's very good response. And the PFS is also excellent with combination. So because of third generation TKIs, because of third generation combination therapies, which have excellent CNS efficacy, there might not be such an enhanced role for WBRT. Okay. So WBRT, you might not need it for patients who have asymptomatic brain mets or only mildly symptomatic brain mets. You can omit WBRT because of the excellent efficacy of third generation TKS or third generation TK based combination therapies. Okay. Also, WBRT can cause severe neurocognitive effects. We know that these patients are living longer nowadays with these newer agents. So you might see neurocognitive defects in them. So that's why you should avoid WBRT, right? So this is unacceptable in this current era. Now, WBRT can still be considered for highly symptomatic patients, right? That is patients with impending herniation or patients whose CNS symptoms are not controlled with steroids. Those patients you can still consider WBRT, but when you're giving it, use conformal techniques such as hippocampal sparing WBRT, SRS where applicable, and fractionated stereotactic radiotherapy whenever applicable. So give conformal techniques when you're giving radiation, but otherwise you can avoid radiation for most asymptomatic patients or mildly symptomatic patients. Only in the patients who have impending herniation or cannot be controlled with medical management, you need to give radiation. And that too should be conformal. Symptomatic 2, the patient is highly symptomatic while awaiting NGS report. Suppose you get the PDL1 testing, you've sent IHC for PDL1, and the TPS score has come out to be 80%. Before getting the NGS report, should you start the patient on chemotherapy plus immune checkpoint inhibitor? So how will you proceed in such a scenario? So you should note here that if you start the patient on chemo plus ICI, and later you get the NGS report and switch towards, we know that ICI is less effective in the presence of a driver mutation, right? Suppose you try to switch back to a anti-EGFR TKI. So what will this do? After an ICI, if you start an anti-EGFR TKI within 3 months, it can lead to high rates of pneumonitis. Okay, that has been observed. Around 15% of the patients who received osimertinib immediately after PD-L1 inhibitor had grade 3 to 4. 15% of patients had grade 3 to 4 pneumonitis and other autoimmune side effects. So that is why in such a scenario, right, you should always start off with chemotherapy alone instead of starting off with a TK. Instead of starting off with chemotherapy plus ICI. Even though the TPS score is high, wait for the NGS report, because if there's a driver mutation, you might not be able to switch out to osimertinib right away. So always start off with chemotherapy alone. Don't add the ICI. Wait for the NGS report. Then, if there's no driver mutation, you can add the ICI. If there's a driver mutation, you can stop chemotherapy and switch over to the anti-EGFR TK. I hope you understood that. So suppose there's tumor progression. What is the next step in the workup? So you should always do a repeat biopsy to establish the mechanism of action, right? Because there are various resistance mechanisms at play causing disease progression. Around 50 to 60% of the patients, you can identify a resistance mechanism. So always we need to know what we are targeting, what is causing resistance. Always do a repeat biopsy. So here you need to know that you should ideally combine a solid biopsy from the progressive site. So suppose you have a new onset lung mets or liver mets, take the biopsy from the progressive side. Also, you can consider doing a liquid biopsy as well. Because on progression, unlike treatment naive, there's tumor heterogeneity. So you can detect some other mutations which you might not have obtained from the site you biopsied, right? So because of tissue heterogeneity or mutation heterogeneity on progression, you can also combine a liquid biopsy with solid biopsy on progression. So what are the sort of mutations that you see on progression? First of all, you have on-target mutations affecting the EGFR receptor. So you have EGFR amplification, you have C797S mutations, which are very commonly seen. And you also have a bypass signaling activation. So other receptors, membrane receptors can be activated, such as MET, HER2, IGFR1. So this is on-target mutation, and the rest of these are off-target mutations. So on-target is EGFR amplification, EGFR C797S mutation, or exon 20 insertion mutations, which can occur as resistance. Then you have off-target mutations, which is mainly through one of the methods is through bypass signaling activation. So another membrane-bound receptor gets activated. So usually you have MET, HER2, IGFR1, FGFR, etc. Right? You also have downstream pathway activation. So elements of the MAP kinase pathway or elements of the PIK3CA AKT pathway can be activated, which can lead to resistance, right? And you have cell cycle components that can be involved, such as CDK4/6 or cyclin D, etc., can be amplified. Or you can have transformation. So we can have transformation in 15% of patients to small cell lung cancer. So you can see here, the mutation profile is different post first, second generation TKI. Like I said earlier, 50 to 60% of patients have T790M mutation. That's the most common mutation. But unlike that, post first generation osimertinib, the mutation profile is different. You can see over here. So you have C797S mutations and MET mutations, which are most commonly seen. So, right. How to tackle oligoprogression. So sometimes what happens is there's not frank progression. Suppose you only get 2 liver mets or you get a single brain mets, right? So when you're treating an EGFR mutated patient, if you have oligoprogression, you should always, before switching the anti-EGFR TKI, you should always target the oligoprogressive sites with local treatment. So suppose you can give SBRT, or suppose you can resect the patient, resect the oligoprogressive site, or suppose you can, give SRS to a single brain mets, right? So if you have oligoprogression, is usually 1 to 5 sites, which you can target locally with radical intents, such as with SBRT resection or SRS. In those cases, you can treat locally and continue the same EGFR TKI with oligoprogression in 1 to 5 sites. Okay, so that's how you tackle oligoprogression. So now, coming to treatment in later lines, so post third generation TKIs, like I said, 50 to 60% of the patients will have an identifiable resistance mechanism. So you can treat second line onwards based on 2 approaches. So you can have a targeted approach based on the resistance mechanism, or you can have a non-targeted approach. So the targeted approach will be if you identify certain mutations, such as if you identify a trans C797S mutation, you can re-challenge with the first, second generation anti-EGFR TK. So after giving osimertinib, if you have a trans C797S mutation, you can give geftinib, and that will still work post osimertinib. So that is the beauty of this mutation, right? You can re-give, or if you have not given earlier, you can give a first or second generation anti-EGFR TK. That works in trans C797S. Cis C797S, you can give cetuximab plus brigatinib, or right. So cetuximab plus brigatinib can be given. Then MET amplification, you can give osimertinib plus MET inhibitor. You can give chemotherapy plus amivantamab. This is based on the Mariposa 2 trial. We'll talk about that later. So MET amplification, osimertinib plus MET inhibitor, or chemotherapy plus amivantamab. We know that amivantamab is anti-MET as well, right? Then small cell lung cancer, if it transforms, you can give platinum plus etoposide, like we treat small cell lung cancer. Now, coming to non-resistance targeted approaches. So this is, you can give regardless of what a resistant mutation mechanism comes, or suppose you don't find a resistance mechanism on progression, you can give these regimens. So one of them is chemotherapy plus anti-VEGF inhibitor. So you can give docetaxel plus ramucirumab based on the Revel trial, or you can give platinum plus pemetrexed plus bevacizumab based on the E4599 trial. Okay, so combine it with VEGF inhibitor, chemotherapy plus VEGF inhibitor. Another combination is chemotherapy plus anti-VEGF plus anti-PD-L1. This is called the ABCP regimen, which consists of atezolizumab, bevacizumab, carboplatin, and pemetrexed. So this is the data comes for this from the subgroup analysis of IM power 150 and from the Atlas trial, which showed that ABCP, even though it is an ICA-based regimen, when you combine with bevacizumab as well, right? So chemo plus bevacizumab plus atezolizumab can have PFS benefit in post EGFR TKI progression. This is based on a subgroup analysis of IM power 150 and Atlas trial. Then chemotherapy plus amivantamab was approved post progression on osimertinib based on the Mariposa 2 trial, where it showed a PFS benefit over chemotherapy alone. And you have anti-HER3 targeting ADC such as patritumab deruxtecan based on the HERTHENA trial. Moving on, recently also based on the Tropion Lung 05 trial, you have another ADC, TROP targeting ADC, that is datopotamab deruxtecan, that has been approved. So all of these are non-resistance, that is, there's no resistance pathway identified, or that particular resistance pathway cannot be targeted. You can use a broader approach, and these are all the broad approaches that you can use, right? These are non-targeted approaches post progression on osimertinib. So that's the this was asked in the recent DNB exam as well. The post progression, how do you approach? What are the mutation patterns on target, off target, and how do you treat the mutations based on a targeted approach that is based on the resistance mechanism or based on a broad approach? Okay, I hope you understood that. Now, coming to the next mutation, it is the ALK mutation. It's the second most common mutation seen. Basically, it is, anaplastic lymphoma kinase is the full form, and it's a tyrosine kinase that it's apparently expressed in a variety of tumors. It was initially identified in anaplastic large cell lymphoma, and it was first described in non-small cell lung cancer in 2007, and it's seen in 4 to 10% of all adenocarcinomas, and it is a fusion rearrangement seen involving the ALK gene, right, on the short arm of chromosome 2p. So this ALK mutation, right, what happens is that the 5' end of EML4 gene binds to the 3' end of ALK gene, and fusion of the 5' end of EML4 gene with the 3' end of ALK gene results in EML4 ALK inversion fusion. Okay, so it's a fusion mutation, fusion product that leads to carcinogenesis between EML4 ALK, EML4 and ALK. So there are various, depending on the fusion point, right? So this, the interesting thing is ALK always fuses at the exon 20 position. But this EML4 can fuse at various other positions. So based on the position of EML4 with which exon 20 ALK fuses, you can have various variants of EML4 ALK fusion. So most common is E13, A20 or variant 1, which is seen in 33% of patients. Then second most common is variant 3, E6A20, which is seen in 29% of patients, and variant 2 is seen in 9% of patients. So variant 1 is most commonly seen. Variant 3, which is E6A20, is second most common. This variant 3 is important because it is associated with inferior outcomes, right? So that's why variant 3 is got slightly less, it's got poorer outcomes. So that is why we need to identify that variant and treat it more aggressively. You can also rarely have ALK fusions with other partners such as KIF5B as well, which is the second most common fusion partner, although that is still considered to be rare. So ALK mutated tumors, they are seen in young non-smokers, adenocarcinomas associated with very high incidence of brain mets, around 50 to 60%. The brain mets are usually cystic in nature, as you can see here, and they're associated with a high rate of thromboembolism, and most of these patients present with DVT. So testing for ALK driver mutation, like I said earlier, we treat with test with NGS on both DNA and RNA, and so basically we use an RNA NGS via amplicon technique, right? So as part of broader testing, we do NGS on with DNA plus RNA to test for fusion mutations as well as other mutations. So RNA is used to test for ALK mutations because these are fusion mutations, right? And RNA has, because the introns have been spliced out in RNA, fusion mutations can be detected with higher sensitivity based on RNA-based NGS. Okay, that is why RNA-based NGS has a higher sensitivity for fusion mutations. So that is how we primarily detect ALK in the current day and era. Earlier, we used to detect via IHC. Okay, there's a Ventana ALK D5F3 CDX platform. It is through IHC that we used to detect ALK. So coming to the treatment, ALK inhibitors, we have first, second generation, third generation, ALK inhibitors. So first generation is crizotinib. Second is ceritinib, alectinib, and brigatinib. And third, we also have another called ensartinib, right? So these four are there. Then third generation ALK inhibitors are lorlatinib primarily. So coming to all these drugs, let's quickly go through their profiles. So crizotinib is given a dose of 250 mg BD with or without food. CYP3A4 interactions are seen. Hepatic renal dose modifications are recommended where necessary. The most distinct side effect here is vision disorders, so diplopia, photophobia, photopsia, reduced visual acuity, blurred vision, vitreous floaters, visual impairment. All of this can be very commonly seen. Others include myelosuppression, neutropenia, thrombocytopenia. You can have QTC prolongation, you can have bradycardia. So always do an ECG, or at least on a monthly basis, on baseline and monthly, to look for bradycardia, right? And if the patient is on any beta blockers or any such drugs, you might have to change the drug if you see bradycardia along with an ALK inhibitor. Hepatotoxicity, ILD, and GI toxicity. So all these can be seen, right? Myelosuppression, visual disturbances, QTC prolongation, bradycardia, ILD, hepatotoxicity, right? All of this can be seen with crizotinib. Crizotinib also has minimal blood-brain barrier penetration. The blood-brain barrier penetration is poor compared to second and third generation. Second generation TKIs is the first drug was approved as serotonin. So serotonin was given at a dose of 750 mg OD on empty stomach. But what they found was that this had increased GI toxicity with 750 mg OD. So they found that you could give a reduced dose of 450 mg OD with food. So if you're giving with food, currently most of us practice with food, give 450 mg OD. So hepatic dose modification is seen, CYP3A4 and CYP2C9 interactions are seen. Most distinct side effect here is diarrhea and GI toxicity, which is reduced when taken at lower dose with food. Others are hepatotoxicity, ILD, QTC prolongation, bradycardia, and you can also see hyperglycemia and pancreatitis with serotonin. Now, coming to the other second generation ALK inhibitors, you have alectinib, which is very commonly used. Until recently, when we had lorlatinib, alectinib was the preferred second generation ALK inhibitor, right? So 600 mg BD with food is the approved dose. Dose modifications might be required for hepatic or renal impairment, and interactions with CYP3A4 inducers and inhibitors are seen. Common toxicities are hepatotoxicity. So liver function should be monitored 2 weekly for 3 months, for the initial 3 months. You can also have severe myalgia and CPK elevation. So always look for CPK elevation 2 weekly for the first month. So look at it, every 2 weeks for the first month, because there can be myalgia and CPK elevation, and sometimes it can also cause rhabdomyolysis. Otherwise, you also see renal impairment, ILD, and bradycardia. So those are toxicities seen with alectinib. Interesting ones are hepatotoxicity and CPK elevation. Then brigatinib is the other second generation TKI. So the dosing here is slightly different. You give 90 mg OD for 7 days, followed by 180 mg OD with or without food. So you give a lower dose for the first 7 days because there's a high risk for ILD during the first week of treatment. So you start off at 90 mg OD, then escalate to 180 mg OD. Once again, CYP3A4 induces interactions are seen. It can also cause hypertension, and along with that can also cause bradycardia, visual disturbances, CPK elevation, pancreatitis, hyperglycemia, etc. So some of these toxicities are overlapping, as you can see, and some of these, each drug has a distinct toxicity as well. So this is the evidence. You had the Profile 1014 trial, crizotinib versus chemotherapy, showed a PFS benefit, right? Then you had the Ascent 4 trial, which looked at second generation serotinib plus chemotherapy, showed a PFS benefit. Then the subsequent second generation trials were compared with first generation TKI, right? So only crizotinib and serotinib was compared with chemotherapy, showed a PFS benefit. Subsequent second generation drugs were compared with first generation crizotinib. So you have for alectinib, you have 3 trials. Okay, you have the Alex trial, which is done in North American patients. You use 600 mg BD of alectinib versus crizotinib, showed a PFS benefit of 35 months versus 11 months, as well as an OS benefit. Then you have the Alacia trial, which was done in Asian patients, which looked at alectinib plus versus crizotinib. Here, once again, you had a PFS as well as OS benefit. Then you had an interesting trial called the JLX trial, which was only in Japanese patients, right? And that used a lower dose, 300 mg BD, but still you had a similar PFS benefit as seen with the Alex trial in North American patients. So possibly a lower dose did work in that particular ethnicity, and which led to similar results. Although we currently still give 600 mg BD, but this JLX trial used a lower dose, but still produced similar results. Then, of course, you have the Alta 1 trial, which compared brigatinib with crizotinib, also showed a PFS benefit. So we'll focus on the Alex trial for alectinib, compared alectinib 600 mg BD versus crizotinib. And as you can see here, it led to a PFS benefit of 34.8 months versus 10.9 months, and that converted to an OS benefit. So once you have given your first and second generation TKIs, this leads to resistance. Okay. And usually it is a on target resistance post first and second generation ALK inhibitors. So post first generation TKI, most common one seen is L1196M, right? And the second most common one seen is G1269A. So these on target mutations are seen with first generation TKIs. So both these mutations confer resistance to crizotinib. On patients with second generation TKI, you see what we call the G122R mutation. So post second generation TKI, you see the G122R mutation, and this causes resistance to second generation TKIs, but lorlatinib still works in these patients. So lorlatinib is a third generation drug. It still works in these patients who develop G122R mutation on second generation TKIs. So that's the mutation profile. It's usually on target post first and second generation TKIs. Right. So coming to the third generation ALK inhibitor, the big daddy, that's lorlatinib. So it is given at a dose of 100 mg OD with or without food. You have CYP3A4 interactions, which are very strong. So the distinct side effects here are CNS side effects. Usually they're grade 1 and 2, they're manageable, and they're usually seen within the first 6 months. Okay. And later on, they're not as commonly seen. So they include seizures, hallucinations, cognitive function changes, mood disorder changes, speech and mental status changes, and decreased sleep. Okay. So CNS side effects, grade 1 and 2, most commonly seen within the first 6 months only. Later on, they become less prevalent. Then you get hyperlipidemia in almost 90% of the patients, and most of these patients will require, statins. And the approved statin is rosuvastatin. Okay. Other side effects seen are weight gain, edema, peripheral neuropathy, ILD, AV block, and hepatotoxicity. Especially if you're giving strong CYP3A4 inducers, it can cause increased hepatotoxicity, right? So this is the evidence for using lorlatinib came from the Crown trial, which looked at lorlatinib 100 mg OD versus first generation crizotinib 250 mg BD. And what did it show? The updated analysis shows the PFS shows the median PFS has still not been reached. Despite 5 years of follow up, the median PFS has still not been reached. And at 60 months, that is 5 years, the PFS is 60% at 5 years compared to 8% crizotinib. So excellent sustained PFS benefit is seen with lorlatinib in most patients to the point where the median PFS has not been reached despite 5 years of treatment, which is unthinkable for a stage 4 lung cancer, right? And of course, there was, even though 50 to 60% of the patients traditionally with ALK mutation had intracranial mets or developed intracranial mets, here you can see there is barely any intracranial progression or development of new intracranial mets with lorlatinib. Around 92% of the patients did not develop or did not have progression of pre-existing intracranial mets, right? Which shows that this patient has this drug has excellent CNS efficacy. So in the current era, how do you sequence therapy? It is lorlatinib based on this Crown trial, the extended follow-up, wherever possible, you should give lorlatinib, right? Um, the issue is that if you give first and second generation TKIs, then this can lead to on-target mutations and compound on-target mutations, right? So suppose if you have suppose you have an L1196M mutation, which is seen with the first generation ALK inhibitor. Suppose you give a first generation ALK inhibitor and you get L1196M mutation. Then you give a second generation TKI. Then you'll get a G122R mutation, right? So if these compound mutations come apart, if both these mutations exist, then lorlatinib becomes ineffective, which is why you should always consider sequencing, especially based on the recent Crown trial update. Lorlatinib should be given first line wherever possible. Okay, if not feasible, you should give a second generation ALK inhibitor such as alectinib, but always try to give lorlatinib upfront. Otherwise, if you give first or second generation TKS, it can lead to compound mutations, which might make lorlatinib resistant later on. So, once again, uh, lorlatinib should be given first line setting wherever possible, but especially you should give it for patients with CNS mets due to the excellent CNS activity with lorlatinib. right? So lorlatinib, wherever feasible, give it in first line. If not feasible, at least give it for patients with CNS mets, and you should give it for patients with variant 3 mutation. ALK EML variant 3 fusion has poor outcomes with first and second generation TKs, as you can see here, poor outcomes with crizotinib, poor outcomes with brigatinib, poor outcomes with alectinib, right? You can see here, variant 3 has poor outcomes. But lorlatinib, despite having variant 3, has good outcomes, almost on par with other variants, which shows that it is increased efficacy in variant 3, unlike first and second generation ALK inhibitors. So variant 3, always give lorlatinib. You can see here, this is the data from the Crown trial subgroup analysis. Even variant 3 has median PFS of 60 months, right? Which is almost on par with your other variants. Also, TP53 co-mutation, that is a poor prognostic factor. Even there, in that case also, you should give lorlatinib. You should consider giving lorlatinib. So the bottom line is give lorlatinib wherever possible. If not possible, give second generation ALK inhibitor. But always, if CNS mets are there, if variant 3 mutation is there, or if TP53 co-mutation is there, in those three scenarios, you should always consider giving lorlatinib. That's a must. In the other case, you should give it a thought, but in these three scenarios, it's a must. So mechanisms of resistance, like I said, first and second generation TKs have on-target mutations, ALK-dependent mutations. I also said that compound mutations such as G122 or L119X6M, right? If they accumulate together, that can also confer resistance to lorlatinib. So those are the on-target mutations, most commonly seen with first and second generation TKs. I discussed those earlier. Now, off-target or ALK-inhibited mutations are seen post-lorlatinib. So first and second generation ALK inhibitors, you see on-target ALK mutations. With lorlatinib, you see off-target or ALK-independent mutations. So these you see it with lorlatinib. So, like I said, with EGFR mutations, this can be an activation of bypass pathway, downstream mutations in AKT or MAP kinase pathway, or in the cell cycle, you can have a histological transformation to small cell lung cancer, right? So, off-target mutations commonly seen with lorlatinib and can involve all these different pathways. So, you can see that from, right? Yeah. Okay. So off-target mutations, especially involving the MAP kinase and PIK3C AKT pathway or other membrane receptors can be activated, and this is usually seen with lorlatinib. So that is the resistance mechanisms for ALK inhibitors. So that brings us to the end of our talk for EGFR mutated and ALK mutated metastatic non-small cell lung cancer. I hope you understood that. I know it's a lot to unpack. I'll upload this video on YouTube. Please go and rewatch it so that you can, really compact and, really create that foundation for your knowledge, because all of this is very important, not just for your exams. Various questions can be asked from this topic, from management of EGFR mutated to resistance mechanisms. All of this can be asked for EGFR and ALK. So go back and rewatch this video when I upload it on YouTube. Make your notes and study, and happy learning. Good night, guys.